Hello and welcome to another edition of the NeuroOp Guru. I'm here with my good friend Dr. Drew Carey from Johns Hopkins. Hi, Drew.
Hey, Andy.
And today we're going to be talking about idiopathic recurrent neuroretinitis and papillitis and whether they're on the same spectrum or not. So, Drew, maybe you could just give us a background about why this is even an important question.
Absolutely. So I think we're all familiar with the standard presentation of acute neuroretinitis. You get a swollen optic nerve, you have exudates in the macula with CME, subretinal fluid, a macular star. We look in there and you go, oh, I know the diagnosis, it's neuroretinitis. And 60 to 70% of the time it's related to Bartonella, and we throw in some antibiotics. We confirm the diagnosis with our Bartonella titers. But maybe 30% of the time everything comes back normal and you're like, oh, what is this condition if it's not infectious? And maybe we'll finish the course of antibiotics and maybe we throw in some steroids and we pat ourselves on the back and feel good about it. Sometimes the patients will have a relapsing condition, and that we think is rather autoimmune and inflammatory rather than infectious. And we don't, other than the clinical diagnosis, we don't really have a great confirmatory tests for it. We don't have antibodies, and it's been previously described as idiopathic recurrent neuroretinitis. But sometimes we see patients who have recurrent optic disc edema. They just know maybe it's recurrent NAION, but they're young and they don't have risk factors. And maybe they get that recurrent optic disc edema in one eye and the other eye has neuroretinitis. And so it's led some people to say maybe these are the same condition or related condition. And the important features are, right, they don't have pain on eye movement, they don't have retrobulbar optic nerve enhancement, and it can be this relapsing condition. So these researchers pooled their cases across Mayo Clinic and University of Minnesota to kind of get a better understanding of the clinical spectrum of this condition or these conditions, and to see if there's any kind of relationship and what do the patients look like in the beginning and afterwards. And so that's how this paper kind of came out.
And have you been treating all these unexplained neuroretinitis with mycophenolate as suggested in the paper?
I think this is a rare condition. I think I may have one or two of these patients. I have put one patient of mine like that I can think of on mycophenolate. I think the challenge is the relapse is that it's not quite like a chronic relapsing inflammatory optic neuropathy where they relapse fairly quickly, and so it's hard to know if you're making a big improvement in your patients. But so this group they collected 30 patients, and 10 had a mixed picture where they had both idiopathic recurrent papillitis in which there was no CME and no exudate, so just disc edema, and also had the idiopathic recurrent neuroretinitis in which they had disc edema and CME and exudates. And then they had 7 that had only the retinitis picture and 13 had only the papillitis picture, with a median onset of about 34 years and 38 years. And they looked, fairly similar otherwise, other than, this picture of whether or not they had the CME. I think in my case, and many of the cases that folks have described, you may get CME in the first episode, and then the recurrent episode, you may just get papillitis. I think like many of our, chronic conditions, that are prone to relapses, but perhaps, also like sarcoid, you may get it quiet and then it can come back months or years later, and trying to balance the risk and benefits of immunosuppression
And did the
is
authors comment on plasma exchange or IVIG in the acute phase?
I don't recall if they discussed that. I think most of the time the patients respond pretty quickly to steroids. It's not really a demyelinating condition, and we're not sure if it's antibody mediated. There's not been an antibody that's been identified. So the use of those modalities would be intuitively not necessarily as beneficial as what we see in our antibody mediated optic neuritis.
So, what do you think the take-home message for our audience is?
I think the take-home message is to keep in mind that if you see a young patient with optic disc edema and their MRI does not show optic nerve enhancement, it's probably not an AON, in a 20 or 30-year-old, especially if they don't have optic dystrophies. And you need to keep in mind that after you've done your thorough workup to rule out things like sarcoid and retinal vasculitis and other things, that they may have this condition that's neuroretinitis or idiopathic recurrent papillitis, even if you don't see the telltale CME and macular star. And if you're seeing relapses in the patient, that you may want to consider putting them on immunosuppressive. And it looks like maybe mycophenolate is better than azathioprine or TNF-alpha inhibitor in this, the limited data we have from a 30 patient retrospective study.
Well, thanks so much, Dr. Carey. This concludes yet another edition of the NeuroOp Guru.
Thanks, Andy.